Welcome, I'm Michelle Kals, Vice President of Business Development and Admissions for Rogers Behavioral Health, and I am your moderator for today's webinar, Diagnosis of Borderline Personality Disorder in Adolescents, When, Why, and How to Integrate Treatment. Today, I'm honored to introduce to you Dr. Peggy Scallon, Medical Director, and Dr. Lauren Ehret, Clinical Supervisor, who lead Rogers Focused Depression Recovery Residential Care for Adolescents. Before we get started, I want to give our participants a quick overview of the format. The webinar is scheduled for 90 minutes, and to receive your CE credits, you must be logged into the webinar for the entire program. A PDF of the PowerPoint slides and a list of references will be available immediately after the program via an email with a link to your personal dashboard on ce-go.com. In addition, a recording of the webinar will be published on the resources section of our website within the next day or two to rewatch. Our speakers will then give a 70 to 75-minute presentation. Following that presentation, I will facilitate the Q&A session. During the presentation, please refrain from using the chat feature as it is a distraction to the presenters and other participants. If you would like to ask our speakers a question during the presentation, please use that Q&A button rather than the chat button to send me a message. At the bottom of your screen, you simply click on the Q&A button on the Zoom taskbar, and I'll review the questions submitted, and then the presenters will address them during the Q&A portion of our webinar. Now, I'll turn it over to our presenters.
Thank you, Michelle. Hi, good afternoon. I'm Dr. Peggy Scallon, and I am here today with Dr. Lauren Ehret to talk about the diagnosis of borderline personality disorder in youth. We'd like to cover the when, why, and how to integrate this diagnosis into treatment of our pediatric patients. So Dr. Ehret and I work closely together on the Focus Adolescent Depression Recovery Unit here at Rogers Behavioral Health in Oconomowoc, Wisconsin, providing residential care to youth ages 13 to 17. Dr. Ehret is the psychologist and clinical supervisor on our unit, and I am the child and adolescent psychiatrist and medical director of the unit. We see many patients who meet criteria for borderline personality disorder, so this is work that we do every day, and we are immersed in treating patients with these issues. So we look forward to sharing with you today. Back to Dr. Ehret.
Okay, so first for today, just a summary of the learning objectives. So throughout this presentation, we're going to try to review some of the common myths and facts with some research data related to borderline personality disorder as a diagnosis, particularly making that diagnosis in adolescent patients, as well as identifying strategies that can be used to deliver that. So even if we determine that we think this person has BPD, some ideas for how to effectively communicate that so that it is as well received as possible. So first, just an overview. So when we're talking about borderline personality disorder, we're talking about these criteria. So per the DSM, you can diagnose borderline personality disorder in individuals under the age of 18. The differences that it asks you to consider are to ensure that these are pervasive. They've been at least a year. The symptoms, again, all of the symptoms together for at least a year. That these are present in a variety of contexts. So this isn't context dependent, like we're only seeing this at home, but never at school or anywhere else. And they have to have at least 5 or more. So just as an adult would, but we need to take a more developmentally kind of nuanced approach to considering how normative or maybe not normative some of the patient's behaviors are. So core behaviors that we have that make up the diagnosis of BPD. So frantic efforts to avoid abandonment, and that could be real or perceived. So we do work with a lot of individuals for which they perceive maybe kind of minor slights, or even things that might be perceived as fairly neutral, like somebody not calling you back or texting you back quickly enough, as this person, has rejected me. So, and then a lot of times concerns about being alone. So frantic efforts to avoid abandonment, other things. So again, connected to that unstable interpersonal relationship. So we have this very hot or cold, people get very close and then to others very quickly, and also have very stormy relationships and then really reject others and push people away, this huge push-pull. This is something that we see a lot, and while certainly adolescents in general may do some of this more than adults, we're talking about to a degree that is substantially more problematic and frequent than your typical same age peer. Identity disturbance. So again, we're looking at markedly and persistently unstable self-image. So, one day I'm highly religious, the next day I'm an atheist. One day I'm really into this, the next I'm into this. So first I'm with this crowd of people, now I'm with this crowd. It's kind of like trying to figure out who you are. And certainly all adolescents are trying to figure out who they are in the world, but this is to a much more substantial maladaptive degree. We also see impulsivity. So in at least two areas that are self-damaging, not including self-harm. So this might be substance use, sneaking out of the house. It could be, other kind of leaving class unexpectedly or walking out of situations. It could be other kind of impulsive behaviors, driving fast, disregard for kind of rules or things like that at times. Of course, we also see suicidal and self-mutilating behaviors. One thing I would highlight is that, sometimes I think one reason why people in the past have been concerned about diagnosis of BPD in both adolescents and adults is, sometimes people have at times over-pathologized or over-diagnosed BPD in folks who are kind of chronically suicidal and self-harming. Not all individuals who are chronically suicidal and self-harming have borderline. Again, you have to have this, the whole package. You have to have all of at least 5 of these symptoms. And also, I think there has been a trend or in the past of diagnosing adults or adolescents that are difficult to work with. And that is also not the case. Certainly not all challenging or difficult interpersonally patients have BPD, and otherwise as well. Sorry, I just got a message on my computer. It might restart. So anyways, we might see difficult patients that do not have BPD, as well as patients who are chronically suicidal and self-harming that do not also have BPD, and we also see those as part of BPD. So we want to make sure that we don't over-pathologize patients just because they are difficult or engaged in those behaviors. They do need to meet all of these criteria, and we also don't want to shy away from giving this diagnosis when it does clearly fit. The other piece we see is affective instability, so reactivity of mood. So a lot of times we get residents here at Rogers who are here for depression, and really a lot of what we're seeing is they aren't even necessarily chronically depressed. It's more so that their mood is very unstable and reactive. So we see great kind of mood instability. And that really is kind of the prominent clinical picture as opposed to a pervasive emotional state, which we'll talk more about with differential diagnosis. Chronic feelings of emptiness, and anger. And then we also do see kind of transient stress-related paranoid ideation or dissociative symptoms, especially when there's been like a major interpersonal kind of loss or stressor. But in general, we see sometimes people that, have concerns about other people to the extent that perhaps they do look a bit paranoid, but they're not actually acutely psychotic. They wouldn't meet criteria for, psychotic disorder. Same thing with dissociation. We do see this, fairly commonly. It's a great way to avoid experiencing intense emotions, and people with BPD often struggle with intense emotions. So makes sense that they may experience that from time to time, but it's not an effective way to manage emotions overall. So that's one thing we work on with folks. So this is just sort of a visual depicting the 4 sort of core areas that make up the diagnosis of BPD that we're looking for if we're considering this for an adolescent or an adult. So again, we have to have all 4 of these. So we're going to need to have interpersonal instability, affective dysregulation, behavioral dysregulation, and then, sort of this distortion in sense of self or affect, so cognitive or kind of identity disturbance. So as I said before, one thing that we want to do when we're considering this diagnosis in an adolescent, and one reason why a lot of people have shied away over the years from diagnosing this, is they say, well, a lot of kids are moody or more impulsive or things like that. So how can you diagnose a personality disorder, and where some of these are more normative? So what I would stress is that in youth that would meet criteria for BPD, this is not normative. These are not sort of normative experiences with impulsivity or mood difficulties or trying to figure out who I am as a person. This is much more severe, substantial, much more problematic, or dangerous. So these are some examples of kind of typical versus atypical behavior, what we look at. So again, with lots of adolescents, we see adolescents who are increasingly moody during adolescence. What is not typical and what is much more concerning is when we have intense, painful, long-lasting moods. So, intense depressions, intense highs, intense anger, irritability, risky mood-dependent behavior. So people running away, self-harming, engaged in other potentially unsafe things. That is not normal, and that is a cause for concern. And so that's kind of more what we're talking about with BPD. So again, a lot of adolescents feel this sort of increase in self-consciousness, feeling like everyone is paying attention to them or noticing them, or increase focus on body image maybe. So that's pretty common. What's not typical is school refusal, unrealistic standards. So I didn't get an A, so I need to self-harm, right? That's not okay. Binging, purging, restrictive eating, those are things that are not typical and unsafe and a cause for concern. Same thing with parent-child conflict. Certainly all adolescents have conflict with parents, but when we're seeing like verbal or physical aggression, running away, threatening to kill themselves or harm themselves if parents don't give in to them or give them what they want, that's not typical. And that is, something that does need more significant intervention. Experimentation with drugs and alcohol. Certainly a lot of students try alcohol or drugs at some point in high school. But what is not typical, again, is when it becomes a problem, where we're seeing substance abuse, selling drugs, or where kind of their peer relationships and their peer group is around drug use. So again, risk-taking, a lot of adolescents engage in risk-taking behavior. What's a cause for concern is multiple accidents, maybe with vehicles, excessive risk-taking with drinking, shoplifting, getting arrested, sexual assault. Sometimes, unfortunately, we have people who have a history of trauma, maybe more likely also to exhibit these symptoms, but also some of these symptoms can put people at risk for being victimized in some way. And so let's work with people on these behaviors and where we may consider things like this in a BPD diagnosis. Certainly in teens, increased interest in sexual experimentation or maturation, things that are, that are not typical and cause for concern. Again, more like we may see in some of these folks that we may diagnose BPD are promiscuity, unsafe sexual practices, casually meeting partners, sexting, interpartner violence. We see more sometimes people who have trouble asserting boundaries. They're really passive or don't assert, may be more likely to be a victim in that case. Teen pregnancy, again, these are all things that we may see more in some of these folks that are searching for identity or belonging through sexual behaviors with people. Increased interest in technology. Certainly most adolescents, we see this. I've definitely seen many more parent-child arguments over technology than probably anything else. But when this is a concern is when they're spending most of their time, many hours a day on the computer or the phone, or engaged in high risk or triggering sort of websites like looking up pro-ana websites and engaging in eating disorder stuff, looking up new ways to self-harm, adult dating websites, other things that are, potentially harmful. That's where we have cause for concern. So some of the myths, again, and stereotypes that we'll talk about today are, one, that you cannot diagnose someone with BPD until they turn 18. Two, that all teens are moody, interpersonally sensitive, and impulsive. Therefore, criteria for BPD are not valid in adolescence because this is common normative adolescent behavior. Because teens are developing, symptoms of BPD cannot be stable, enduring patterns of behavior as seen in adults with BPD. BPD is a chronic and intractable illness, much more so than other mental health diagnoses. People with BPD do not get better. And BPD is caused exclusively by environmental factors or trauma, rather than biology or genetics. So these are some of the myths that or stereotypes that we will talk about and why that is. One thing that sometimes we hear is that, this is all environmental, but actually what we do know about borderline personality disorder is that it really is due to a combination of a number of genetic and environmental factors. So those of you familiar with the biosocial model, that's kind of where that comes from. Interestingly, there was a recent very large population-based twin study, and they found the heritability estimate. So the percentage of, like the variation in dimensional traits that is due to genetic factors is 46%. Interestingly, a similar sort of study found it's 31% with major depressive disorder, yet we certainly see a lot of patients coming in saying this is a chemical imbalance, there's nothing I can do about this. And in fact, that's just really not true. There's always going to be some element of biological vulnerability as well as environmental vulnerability, and there are always things that we can do to help people to improve, regardless of where these difficulties came from. Other myths, so it'll do more harm than good because of how stigmatized the diagnosis is, do more harm to provide it. That most adolescents and their parents react negatively when receiving this diagnosis, that'll ruin rapport with the adolescent and or the parent and negatively impact their treatment as a reason why, a lot of clinicians shy away from giving this diagnosis. That it takes away hope, and that avoiding the BPD diagnosis protects the patient from stigma. So these are some more myths as well about diagnosing BPD in adolescents that we'll continue to talk about. So facts. There's actually a fairly robust literature that supports making the diagnosis in adolescents as young as 11 years old. Now, you know, we were just talking earlier, I personally haven't diagnosed BPD in someone that young, but we do have experimental data that shows that it can be diagnosed reliably and validly in adolescents, and including in people that are, you know, younger than you may think. What we do find with research is actually that the diagnosis offers clarity. A lot of times there's an aha moment when we discuss this with people, like, oh, that makes a lot of sense, right? That's kind of the actually more likely reaction that we might get. It allows us to talk about strategies for managing difficulties, you know, building hope. This is actually a very treatable mental health diagnosis, and especially when people are young and they haven't had the same impact of these symptoms on life. You know, if you have an adult who's been struggling with these things for decades, and now it's affected their ability to maintain a job, to get married, to have a family, like the major kind of goals that many people have in life, versus if we can help someone with this when they're 18 and they can correct some of these things before, you know, that sort of, you know, the time frame in which people commonly do that has passed, like that can have a really big impact on somebody's overall life functioning. So it does offer, there are strategies, and the prognosis actually is fairly good. We know that DBT is effective. There have been a number of RCTs demonstrating that DBT is an effective treatment for adolescents with borderline personality disorder or traits. And we also have seen that BPD traits, like youth who have these traits, they can be malleable. Yeah, so I think the main, you know, point with this is that there is hope for these individuals, and there is a strong evidence base that we can, in a reliable and valid way, provide this diagnosis to individuals under 18.
So slide 16 just talks about the myth that you can't diagnose someone with BPD until age 18. So we're just showing you the pages here, you know, out of the DSM-5 that actually describe that you can. You know, one of the biggest reasons that I hear from folks that is a barrier to making this diagnosis is they think that it can't be made until 18. It's sort of a urban legend, or it's sort of an older way of thinking, but I think it persists out in the world. And so people just think, you know, you can't make that diagnosis before 18, but it's actually not true. So we wanted to show you that here in black and white, that you can. The symptoms needed to be present for at least a year, and the impairment needs to be pervasive, persistent, and unlikely related to just that developmental stage. And again, to meet criteria, of course, in youth as well as in adults, you need to meet 5 out of the 9 diagnostic criteria. Yeah, so I'll let you go back.
So there's
slide 17.
Yeah, so there's that. So again, like you can, and this is also true of ICD-11 and also the NICE guidelines in the UK, which provide like evidence-based treatment guidelines over there for their National Health Service, also recommend diagnosing adolescents when the symptoms are clearly present and they clearly do meet criteria for this disorder. So I'm going to talk a little bit about differential diagnosis, because I think that that's really challenging and is also a barrier to people being comfortable providing this diagnosis. So certainly with any diagnosis, if the diagnosis is better accounted for by another mental health diagnosis, then we don't want to diagnose BPD. So the one thing I mentioned before is that, you know, just because someone is engaged in self-harm, you know, even kind of chronic self-harm or suicidal ideation, you know, that doesn't necessarily mean that they have BPD. So there was a really interesting recent study on non-suicidal self-injury in adolescents as well as BPD. And one of the things that they found was that actually, so 58% of the adolescents who had BPD were reporting suicidal injury. So actually that means 40% of the sample was of these adolescents that did meet full criteria for BPD were not engaged in regular ongoing non-suicidal self-injury. Now that doesn't mean that they've never engaged in that. That just means currently they're not. On the other hand, there were also a number of adolescents who engaged in non-suicidal self-injury who did not meet criteria for BPD. So 51% of female adolescents engaging in non-suicidal self-injury met criteria. Well, that means that like 49%, so roughly half of them didn't. So, you know, that just because you have someone that is demonstrating difficulties with suicidal ideation and ongoing kind of chronic self-harm, you do have to have, again, all of the criteria. And we want to make sure that those are really present before we provide this diagnosis, because you don't want to provide this diagnosis if it's not an accurate description of what the person is dealing with, and if it doesn't predict kind of what types of treatment would be most helpful. We also get a lot of individuals who come to our clinic who have been given bipolar diagnoses. You know, this is one thing that I think is a lot easier to see in a residential setting when they're living here, or you know, even in like a day treatment setting where they're there every day for a large portion of their day, spending like 30 hours a week there. You really see how this person is kind of more generally when you're in that setting versus in an outpatient clinic. It's really hard. You have to rely a lot on what this person, how they describe their experiences and how parent describes their experiences. And so we do get a lot of people who come in with bipolar diagnoses, and you know, when we look at it, they've really never met criteria for a full manic episode. And you really can't meet criteria for bipolar disorder unless you've met criteria for, you know, either a full hypomanic or a manic episode. So, you know, what we're looking at when we're looking at the difference here is really kind of the way that it looks, the presentation. We're looking for sustained periods. So with bipolar disorder, you have to have sustained periods of really uncharacteristic, elevated, expansive, or irritable mood, and enough other symptoms to meet full criteria for a manic episode at the same time. So what we often see is a lot of patients who've certainly had symptoms that could be considered part of bipolar disorder, but they've never had them all kind of together at the same time in a clear, like episodic manner, in a way that is clearly distinctly different from this person's usual functioning. A lot of what we see is kind of this person is in general, like, you know, impulsive, and their moods change quite a bit. They have definite mood swings. They do engage in impulsive behaviors and things like that. But the way I think of it is kind of like bipolar disorder is more like Neapolitan, right? Like ice cream. Like we have these distinct kind of episodes. They might kind of overlap a little bit, but you know, again, we have kind of discrete episodes that are, you know, different. BPD is more like funfetti, right? Like everything, we have these like differences, but they're more kind of uniformly spread out. Like this person is frequently, you know, engaged in some of these impulsive behaviors. So while people with BPD might engage in some behaviors that someone in a manic episode, someone else in a manic episode may engage in, if it's not, you know, along with a host of other symptoms, a clear like change from baseline, you know, then that may not be really best accounted for by bipolar disorder. And this is actually really important. I think we do see this a lot. But the problem with bipolar disorder versus borderline personality disorder is that the evidence-based treatment for those are actually fairly different. The prognosis is different, recommendations may be different. So it's actually fairly important that we try to make this distinction. Now, sometimes it's really hard and adolescents, right? Like, and sometimes we may not know what these adolescents are going to look like when they get older. Like some of these adolescents may go on to look more like some of the adults we see with bipolar disorder. But right now, if right now that's not what we're seeing, if right now we're seeing more like the funfetti sort of presentation of symptoms, and we haven't had any, you know, manic episodes, then we want to, you know, take another look at that. The other thing I look at with that too is like, you know, family history, things with bipolar. Does this person have a significant family history of like bipolar, schizophrenia, or, you know, other kind of severe persistent mental illness? Or, you know, actually one thing sometimes we see with borderline personality disorder is co-variation in families with more like ADHD or other kind of you know, mood disorders or things like that, but not necessarily with a strong, you know, family pattern of you know, more severe persistent kind of mood or psychotic disorders. Now, one thing that we talk about is also people are concerned about, you know, misdiagnosis. So I don't want to, you know, give this person this diagnosis and then have it be wrong. Well, actually, and people are worried that in an adolescent, that would be more likely. Well, actually, what we find is that that's just as likely in adolescents as it is in adults. And actually, in adults, people frequently misdiagnose BPD. You know, there was a really interesting recent sample in which they looked at this in patients being admitted into an inpatient unit. And looking at these cases, they determined that 68% of them were incorrectly diagnosed. And for the ones that were misdiagnosed, so they had BPD but were not diagnosed with BPD. Oftentimes what they found is that these individuals were significantly younger. So again, kind of relevant for our population here and may reflect some bias away from giving this diagnosis in younger, even young adults. They were prescribed more psychiatric medications than the ones that were correctly diagnosed. And that's definitely concerning and definitely something I think we see a lot in our clinic is we see folks that are on a boatload of medications that have, some of which can have fairly significant side effects that cause other problems. And also they're not, we know from quite a large amount of research that they don't work for BPD. But this is kind of what we were seeing here. These folks that were misdiagnosed, again, they're younger, they're given more medication, they tended to be more depressed, had greater suicidal ideation, and were more likely to be readmitted. So, you know, misdiagnosis is common, and it may be more common in some of the individuals that are, you know, adolescents or young adults that are presenting with some of these, and that this does have this can result in detrimental outcomes or be associated with that. Medication management, I know Dr. Scallon could probably speak more to this as well, but really, you know, they've had multiple large-scale studies, you know, lots of RCTs and lots of, you know, meta-analyses, and basically they found that no medications show promise for the core symptoms of BPD. So for, you know, chronic feelings of emptiness, identity disturbance, abandonment, or interpersonal kind of fears, certainly medications may help with other comorbid difficulties. So, you know, maybe other anxiety or PTSD, or someone does have bipolar disorder, certainly, but not really for BPD.
Yeah, I agree. I mean, and when this certainly is a match for what we experience with the kids in our unit, they come in on many, many meds, and we almost universally get the history that they haven't really helped that much. Abilify is at the top of the list, and you know, polypharmacy or many medications certainly has no evidence base and comes along with a lot of side effects. So this is consistent with what, you know, we see on the unit. And I think it's important to, you know, it identifies the core symptoms of BPD: emptiness, identity disturbance, and abandonment. You know, meds are the wrong tool for that, so to speak. That really is a therapy driven kind of a solution, or should be. And so, you know, we do see that medications help with the comorbidities. I'll talk a little bit more about that in a little bit. But yeah, I agree with the slide for sure. But it doesn't certainly shield our kids from getting prescribed lots and lots of meds.
Yeah. So that is one reason why I think, you know, careful assessment of this and diagnosis is important to avoid some of the problems with that. Other outcomes, so looking at rates of suicide, there have been a couple of really large scale follow-up studies of adults with borderline personality disorder, a couple of which that have been going on for over 25 years at this point. Over at McLean, the McLean study of adult development, Joel Paris had a study also that he was following people at their 27-year follow-up. So again, a long time, they were finding that 10% of people died by suicide. Now, other studies have found that this rate, this mortality rate due to suicide, also, again, probably depends on the follow-up length. If you have more time in which you're following people, you're probably going to have more people in which will complete, but 2 to 17%. Now, what this does mean, okay, so yes, that doesn't sound great, that like 10% of, you know, the folks in the study died by suicide. What it also means is that 90% of people didn't. So 90% of people with BPD, the study was started like long before DBT was really available or disseminated, or that we had a lot of other strong evidence-based treatments, and so still 90% did not. So this is, you know, certainly still scary, and I think also shows that it doesn't mean that it's, you know, like these are things that can be managed and people can build lives with living. It doesn't have to be kind of, sometimes it feels riskier than perhaps it is. Prevalence rates, one thing that I think is interesting is that across some of these studies of adolescents and adults, finding fairly similar in some settings, except for emergency departments and inpatient settings, higher, they were finding pretty astounding rates. But again, like outpatient mental health settings, about 11% in adolescents, 10 to 12 in adults. Community samples, 0.9 to 3.6 or 6.9 for BPD traits, not full diagnosis, very similar to adults. So the rates that we're seeing in adolescents are, you know, fairly comparable to that of adults, and this is across a couple of different countries.
So I'm going to comment some about sort of what this can look like on our unit. You know, like I said, our unit is comprised of teens 13 to 17 who are referred with symptoms of mood disorder. Many of them have had multiple suicide attempts, multiple inpatient hospitalizations, PHP, IOP, and other residential stays. And so we see kids that are really quite affected by this. And, you know, they come in having had many medications, they have had many diagnoses. It's a pretty confusing situation. And so, I mean, I feel so lucky to be able to work in a model of residential care where we actually have kids for a little bit more of an extended stay, and we can peel back the layers and get to know them. My, you know, kind of coming of age with this phenomenon, I graduated from medical school in 1992 and started psychiatry residency right after that. And that was the time that, you know, branded atypical antipsychotics were coming on the market. Risperdal, olanzapine, and then later meds like Seroquel, and Geodon and Latu, all of them have followed. And this was just a huge financial slice of the pie for the pharmaceutical industry. And this was also kind of before more controls were placed on marketing to physicians. And so we had lots of marketing efforts for prescriptions, and essentially they're sort of marketing the diagnosis of pediatric bipolar disorder. And there was a lot of hype, we're missing the diagnosis of bipolar disorder. And, that became that diagnosis exploded. It was in the media. Thankfully, in DSM-5, when in 2013, the work groups had to really, kind of go back and forth about whether we were going to expand the criteria to include pediatric or developmentally appropriate criteria. And what they found was that in the prepubertal population, that diagnosis really did not have validity. And so it looked like those kids, after they followed them, who were given the diagnosis of bipolar disorder, particularly prepuberdally, went on to have a whole variety of other diagnoses, but not persistent, bipolar disorder with the time criteria, manic episodes that are a distinct departure from their normal baseline. And so thankfully, that diagnosis was not expanded in 2013. And that pendulum swing has sort of decreased somewhat. And while the overdiagnosis of pediatric bipolar disorder is still out there, and we get many kids who are admitted with that diagnosis, it's changing somewhat. So layer that on top of the fact that at the time that bipolar disorder diagnosis was being heavily marketed in youth, there really wasn't dissemination or much of an evidence base for DBT. I mean, it was there. Marsha Linehan had been developing this, but it hadn't been as widely disseminated. There weren't DBT centers that you could send a patient to. And hello, you're back. I'll just finish this one part and let you get set up. Okay. So there really was not availability of DBT, if you will. There certainly was not marketing of DBT, and people felt like, giving that diagnosis was sort of hopeless. It's really severe. People thought doesn't much get better. People thought, we know those things are not true necessarily. It can get better, and there isn't any treatment. And so that kind of fed into the pre-existing stigma of that diagnosis. And, so that was one of the factors. Now, like I said, all of the major professional organizations, ACAP, American Academy of Pediatrics, and so forth, have, really come up to speed in making that diagnosis more. There is dissemination of DBT resources. We know prognostically that early diagnosis and treatment is effective and really does help these kids and is very important in their treatment. And so we're coming up to speed, but that was one reason we were so excited to have this conversation today, because, we see it firsthand that this really is the way to help these kids. And I saw, with the era of the atypical antipsychotics, you'd prescribe them to these kids. They would gain a ton of weight, 40 pounds. It was visible. They didn't learn new coping skills for managing their strong emotions, but it was like a big kind of wet blanket, just dampening everything down. And sure, it kind of calmed things a little bit, maybe took the edge off, but the kids really were not that much better, and they just sustained sort of a perpetuation of the symptoms and further, delay in their social and emotional growth. So, I'm very thankful for that, and also feel like any opportunity that we can have to talk about borderline personality disorder in youth, using and talking about the diagnostic criteria, shedding our own stigma about that, because, some of us may have, some of that old vestiges of messages that we were given. But as we, look at it, talk about it, share it with our patients and with the patients' families, most people feel that this is really just such an opportunity to, plug in the treatment that we need, learn new skills, and help the kids. So.
Yeah, thanks, Dr. Scallon. I think that brings me to this. So, another reason why, people have been concerned about providing this diagnosis is, again, like it is very stigmatized. And one of the things is, these people don't get better. These are people that have chronic issues, or, or they do get better. Maybe they mellow out in like middle age or something like that. But that's actually not what we see with some longitudinal studies. So even way back in the 80s, people did some follow back studies. So looking at like getting in touch with patients who had previously been in treatment at a given institution. And actually what we see is that we see gradual improvement in psychopathology, actually, better course than some things like schizophrenia or other kind of more severe mental illness like that, worse than depression, but definitely a lot better than the prevailing kind of notion of the time. I think a lot of people, one reason is that a lot of times people see patients with BPD in their clinics when they're at their worst, or you see kind of like the frequent flyers at the inpatient unit, but that may not be reflective accurately of how people are actually functioning more globally over time, or how most people with this diagnosis are functioning. So this is some old data, but actually what we see is that it is actually pretty consistent with more recent data, that with better methodology that has been used to follow adults with BPD over time. So what they found is actually that people admitted and they followed them for 20 years. Sometimes they have some, setbacks and things like that, but overall they make a steady recovery. And this is, so this is looking like 10 years out. If the average participant at the outset was 20, this is when they're 30. So it's not like, and when they're 50 maybe, and after they've had kind of a lifetime, this is much shorter than that. And this is definitely before, not even just DBT, but a lot of other things, even a lot of other psychosocial treatments or medications or things like that were available. So like I said, again, one thing I wanted to highlight too is that a lot of times people are concerned about diagnosing BPD in youth because they feel like it needs to, it does need to be something that is persistent, right? This needs to be something that is persistent, consistent, seen across multiple settings. And people feel like we can't see that in an adolescent because there hasn't been enough time yet. And actually what we see when we look at adults is that perhaps overall BPD is just not as persistent as one may think. So this is an extremely well done study by John Gunderson and another one by Mary Zanarini's group out in Boston. This one's the CLIPS. So they recruited a number of treatment-seeking adults, 18 to 45, with borderline personality disorder, another larger group with other personality disorders, MDD group, and followed these people for 10 years. And they actually were able to continue to get 66% of the sample, which I don't know if any of you have ever been involved in trying to follow patients over time, but it's really hard. So it's hard even after a year or two sometimes to retain people. So 10 years, that's actually quite good. And what they found is actually that 85% of patients with BPD remitted, as in no longer met criteria for BPD. And the requirement for this was that they could not have met criteria for BPD for at least, it had to be sustained for at least a year. So the recovery had to be for at least a year. So that's a lot of people. So actually, that's saying that most people eventually remit. And 12% relapse. That's a much, that's a much lower relapse rate than, say, folks with depression, even major depressive disorder. More people with MDD are going to have a relapse of symptoms in that time frame, or bipolar disorder, other things like that. So, and this was true. They did find a lower relapse rate, but also a slower time to relapse than patients with MDD or other personality disorders. Now, these folks did still continue to show impairment in social functioning with kind of more modest improvement. So there are certainly some things that a lot of times these people do continue to struggle with over time. And also, these are also folks who overall, we're not seeing this global picture of, folks that are grossly kind of impaired and that it's not getting better. So this is the clipped study over time. Again, this is adults, but even with the adults follow-up years, so 0 to 10, even by year 2, we're seeing substantially less symptoms than, and these are all 9 of the BPD criteria. We're seeing a lot fewer symptoms even after 2 years. So than at the initial outset. So again, perhaps, while yes, with adolescents, certainly we do need to see that it is persistent and consistent across time. And actually, but I don't think it's realistic to expect them to, be more perhaps persistent with symptoms than adults. And because adults aren't actually necessarily as chronic as perhaps once thought. The other thing is these, more unsafe behaviors tend to fall off the fastest, so and to the largest degree. So self-injury, suicide attempts, the abandonment, trying to avoid or escape abandonment, those behaviors tend to fall off to a greater degree, such that by 4 years, identity disturbance, the abandonment, the stress-related paranoid ideation, self-injury only was present in 20% of the sample. So again, it is long lasting, but it's not 30 years, decades kind of that people stay that way. Same thing with the McLean study. So they required recovery as a definition being 2 years in which they fully remitted. So people had to be at least 2 years of, free from meeting this diagnosis. And that was still 60% of their patients after 16 years had achieved that. Also, they were able to continue following these folks at the 24-year mark. They were able to look at suicide as well as other death of other causes. And one thing that is perhaps interesting, they found 5.9% rate of suicide. One thing that's interesting is that that's about half of some of the older studies. And that was one thing that they pointed out in there too, because during this time frame, we have had the development of DBT and other interventions to help these individuals. And so there was some suggestion that perhaps that's having an impact on the actual mortality rate. The other thing that I really want to point out in terms of relationship to adolescence is that patients with BPD who died prematurely, so either by suicide or non-suicide related causes, so heart attacks, other accidents or other natural causes of death, most of the people who died prematurely were not recovered. So what we know is that patients, when they're younger, again, according to a lot of meta-analyses and other more experimental studies, find that young people perhaps are a little bit more malleable. If you think the time course of someone's life, if we can intervene again when they're early and well, when they're 18 or so, it's probably, you can prevent perhaps some of the more major life-altering changes, as if those symptoms were to continue on until they were 25, 30, whatever. It's important that we address this and we're able to treat it accurately, because there are actually mortality concerns related to untreated or non-recovery. And not just dying prematurely of suicide, but also of other natural causes, some of which may also be indirectly related to symptoms of BPD, overlap with other things, with lifestyle changes related to exercise, eating, kind of things like that, risky kind of lifestyle things. So patients who did not achieve recovery were at disproportionately higher risk of early death than recovered patients. So that is concerning from that. We want to help people achieve recovery, and therefore being able to diagnose this accurately and early to be able to help people make changes earlier on is certainly helpful for that. Other factors, again, this has been with adults. We don't have as much data on adolescents, but these longitudinal studies, other things that predicted treatment outcomes. So earlier time to recovery. So things that predicted having achieved recovery earlier, so achieving better and earlier kind of recovery, were less chronic or severe course of illness. So no psychiatric hospitalizations prior to the index hospitalization. They did recruit people in the context of an inpatient stay. Absence of other, comorbid anxious cluster, so comorbid personality comorbidity. So, again, if we're looking at less chronic, so if you are able to give someone treatment earlier on in their course of illness, by definition, you can help some of those people at least be less, not become kind of chronic cases. So that's helpful for having better outcomes overall. Other things that we see here, higher IQ, people who are overall have greater intellectual problem solving kind of abilities, may have better adaptive kind of functioning, tend to achieve earlier recovery. Also, if someone has a history of being more functional, so having a good full-time vocational record, so work history, 2 years prior to the index admission. That was also something that, this is someone, maybe they've had setbacks, but they have been able to be functional. That's another thing that predicts kind of good outcomes for these individuals. And likewise, kind of temperament, other factors, high extroversion, high agreeableness, probably people that are, easier to develop better social that you may be able to develop better social relationships or have more social support if you happen to be more aggressive, or not aggressive, extroverted or agreeable. So again, just some prognostic indicators that we've gathered from some of those longitudinal studies that were very well designed that do have implications, I think, for our intervening earlier on with some of our younger patients. Likewise, there was a twin study that they did in the UK, fairly large, with adolescents, in which they followed these people over time. And interestingly, borderline symptoms that they assessed at age 12 via parent report, and then followed through age 18, in which they looked at self-report as well as some other records and other things for them. They found that people who were younger and exhibiting these symptoms at a young age, even when they were emerging kind of adults, these people still had increased likelihood of having difficult personalities, right? Difficult to get along with, struggle with poor mental health, experience poor functional outcomes, and really most concerning to me is becoming victims of violence. So even though, again, that would be very early to diagnose BPD per se, but providing education related to some of this stuff, getting people access to appropriate treatment, and receiving an appropriate diagnosis when that is clear, is really important so that they don't persist and we have other new problems that may compound what was already an existing problem. Interestingly, so borderline symptoms at age 12 predicted poor outcomes over and above other behavioral and emotional problems during adolescence. So above and beyond issues with depression or anxiety, kind of comorbidity, you might say, oh, well, these people that had more BPD symptoms, maybe they just have overall more psychopathology, right? Earlier onset. Well, even when we account for that, these BPD symptoms predicted poor outcomes, again, even above and beyond, accounting for some of those factors. Oops. And the last part that I think is interesting too is that actually they found that genetic risk was a significant factor in this case because it was a twin study design and they also included some other measures looking at genetic risk. we know that some of this is familial. So, and that actually was associated with most poor outcomes. So, this biosocial model is really important to consider. There are certainly environmental, there's certainly more biological or genetic risk factors, but either way, like we need to, we know that people with these traits do well with things like DBT. And so we want to ensure that folks, get timely access to this so that they don't an appropriate education so that we can prevent things like victimization. Awesome. All right, I'll hand it over to Dr. Scallon.
All right, and you're still advancing the slides, right?
Yeah.
Okay, that's the perfect slide. That's what I wanted to jump to. So I think Dr. Ehret's made a great case for the evidence behind the importance of giving this diagnosis in kids. There is a robust medical literature that supports us doing that. And, it helps kids. It's the best way to help kids. There's no other diagnosis out there that we would, sort of advocate delaying giving accurate diagnosis and treatment. And we shouldn't do that with these kids either. So just to summarize, if we think about what is the purpose of a diagnosis, really is to communicate with other professionals. It is to predict the future as best we can in terms of prognosis. It's to guide us to treatment. So what are the evidence-based treatments for borderline personality disorder? And it keeps us from having a misdiagnosis. Like we talked about, bipolar disorder is one of the diagnoses. The other things that can be in the differential diagnosis here that some of our patients are diagnosed with. And it causes, misdiagnosis can cause us to rely on the wrong kind of treatment. So relying too much on medication, which comes along with side effects, with cost, with delay in time to getting the appropriate treatment. So that is the importance of the diagnosis. And let's jump ahead. And why would I diagnose BPD in an adolescent patient? Well, because it exists. So, the diagnosis doesn't just show up on a person's 18th birthday, of course. That wouldn't be realistic. And so, most of the time, people with BPD are already self-harming before age 18, even oftentimes that's seen at age 13. And, we intervening and getting appropriate treatment really leads to fewer years suffering and more years being well. Let's jump ahead. Okay, I want to talk a little bit about, what actually happens if we avoid giving this diagnosis, and then when we do give the diagnosis. One thing that we see a lot with our kids is this thing that we call illness identity on the unit. The kids have been in a lot of different treatment settings. They have been given many different diagnoses, and sometimes they can kind of attach to those diagnoses, and it can be hard for them to give them up, so to speak. And so, one thing that is helpful about the BPD diagnosis, not only does it help them to look toward skills that they can use, that they can access, but it provides that internal locus of control. And, there is really no downside to learning the skills in DBT, those 4 modules: mindfulness, interpersonal effectiveness, distress tolerance, and emotional regulation, with the 2 of them being focused on acceptance, mindfulness, and distress tolerance, and 2 of them focusing on change, which is interpersonal effectiveness and emotional regulation. And so one of the things that we really do on our unit is emphasize the importance of using skills. Okay, let's jump ahead. And again, I just want to talk a little bit about stigma, both in terms of our patients' self-stigma as well as stigma among professionals. This really is an outdated kind of a notion, and we should be out there dispelling this myth that, this is a diagnosis that portends a bad future or is hopeless or there is no treatment. None of those things are true. There actually is a good prognosis. There is treatment, and conveying the diagnosis provides hope. and leads them away from wasting time, wasting money, and incurring other side effects with the wrong treatment. So let's just jump ahead there. Okay. I want to talk a little bit about how we do this. I can do this pretty quickly. Like I said, we have the advantage of kids coming to our unit for 6 to 8 weeks. Often they've been in multiple other treatment settings before they came to us. And we get the opportunity to just kind of have them come in and we observe them. Often they're on many medications and we generally don't change anything. We don't challenge a diagnosis when they come in. We just let them come in and observe and take their history. And then, over a short period of time, we start to develop observations that we, share together as a team. We get release of information and check collateral sources, and we start to share this information with the parents. Have you ever heard of this diagnosis? If so, what have you heard? Many of them have. Many of them have been told, well, we would give this diagnosis, but they're too young. And then, we get out the DSM, we get out the DSM-5 and we read through the criteria with families, and often families feel very validated by learning, oh, this is a phenomenon, it really does describe my child. And then we convey the idea that there is a lot of hope for this, and there are practical hands-on strategies that they can use. And we present it with a lot of openness and curiosity about their child. And generally it goes pretty well, I would say. So let's jump ahead. Okay, these are the screening tools. We don't typically use, semi-structured clinical interviews or screening tools per se for borderline PD. They exist. We wanted to share that with you so you know they exist, but I don't think we'll spend too much time talking about those. Those are in the notes, and we really rely on our clinical observations. I'm going to jump ahead and just talk a little bit about, there is a case in there that would be helpful, I think, to think through and talk about. But given the fact that we really want to do some Q&A at the end, I would just have you read through the case description of a child who was on our unit. And a couple of things I did want to point out, because it's not self-evident, is this idea about identity disturbance. I do think that the kids who do meet criteria for borderline personality disorder, some of their identity disturbance can take the form of being pretty malleable or pretty prone to social contagion. And I think that compounded with social media, COVID, much more access to some of these things has, kind of compounded that illness identity in some of the kids that we see. Things like TikTok, will show dissociative identity disorder. And so kids can come in with some pretty extreme descriptions of symptoms. I have alters, and these alters take on a lot of different forms, different ages, different names, different roles, different emotional valence, if you will. And that can be a highly charged kind of phenomenon. Typically, we tend to think about those and characterize those when it fits under the auspices of a dissociative kind of a phenomenon. Sometimes kids also talk about seeing things or hearing things. I think some problem comes into play when folks take that at face value. There can be kind of a fantastical side, if you will, even to some of the descriptions of these phenomenon. And usually if we give them some time and spaciousness and focus with the kids on emotional identification and labeling of emotions and communication, they tend to kind of dissipate, honestly. We don't challenge them head on. We don't, take them away, so to speak. But we tend to reframe those sometimes as a means of communication or a metaphor. There's Michelle cueing us that we should move to the Q&A, and that would be fine with me. I think that's totally good. We had a little bit of technical difficulty and we recovered, but all this information is in the slides. So I'd encourage you to take a look, and hopefully that will help you with your patients. Thanks.
Thank you eh, very much for that presentation. And despite the technical difficulty, we're getting a lot of great feedback on the Q&A section. So if you do have a question, please use that Q&A button, not the chat feature in the Zoom taskbar. And we'll try to answer as many questions as we can in the time we have left. If we don't get to your question, please send me an email message afterwards and I'll follow up with you. Okay, the first question that we have today is, can you explain more about a diagnosis for an 11-year-old or how it would look with different disruptive mood dysregulation disorders, for example?
Yeah, so again, please see the slides that had a list of some of the assessment tools. So there are clinician administered interviews, as well as some self-report tools that have been validated in kids that young. Again, like you want to consider the child's behavior and developmental factors in deciding at what point you want to diagnose this. So, and again, like I said, have I diagnosed it in an 11-year-old? No. Does it mean that it doesn't exist or it could never exist? Probably not. If they've found it in some research studies. I think that though I would look at some of those assessment measures that were there. Those would be some tools that you could use to discern kind of typical from atypical behavior in this. And also, like, is this better accounted for by ADHD or other things? The DMDD part, DMDD really, and Dr. Scallon can comment too, we don't see like the identity disturbance. We don't see the interpersonal, like push-pull kind of abandonment or rejection sensitivity fears. It's not so interpersonally charged, and we do see a lot more anger kind of, big kind of explosive kind of experiences with that. And so I think especially those characteristics, certainly they overlap with like the, dysregulated emotion piece, but especially, some of those interpersonal or identity pieces are definitely very different.
Yeah, no, I agree with you that if we're to differentiate, certainly there's overlap between DMDD and BPD in terms of just, emotional reactivity. But the themes, the interpersonal themes, the identity themes, the fear of abandonment are some of those that are more better characterized by BPD. The DMDD diagnosis refers to irritability and explosive outbursts that are not in pace with one's developmental age or phase. And that I would characterize as, a kid who drops their ice cream cone on the cement and just, has a meltdown like no other, and it goes on for hours. That I think could be characterized better in the DMDD category, perhaps, than the BPD, which has more of a relational and identity flair to it.
Thank you. This is a mixture, maybe a multi-level question, but we're getting a lot of questions on why do you think BPD is often diagnosed? And there was even a comment like, are you seeing that it's becoming trendy in the adolescent population, largely influenced by social media?
That DBT is, Michelle?
Oh, I'm sorry, BPD.
Or, what? So is
yeah,
BPD becoming more
trendy?
More trendy.
Yes.
Gosh, I don't see it in that way. I don't see it as being more trendy. I mean, as I mentioned, some of the, data is leading us in that direction to say, hey, we should be giving this diagnosis more frequently. There is effective diagnosis and treatment. ACAP, American Academy of Child and Adolescent Psychiatry, is taking a lead on this and really representing that we should be using this diagnosis. So I don't see it as like a trendy TikTok thing. Like I do some of the other things we're seeing more commonly, the alters and the dissociative identity disorder and voices. So to me, that's not, I don't see this as sort of a trend, trendy kind of a thing. I see it as just, there's more recognition that it actually is real and valid. And I think it is, as it takes more a forefront, it edges out some of the erroneous diagnoses that I used to see more commonly. Like the bipolar disorder, sort of false epidemic that occurred in the mid to late 90s and into the 2000s.
Thank you. The next question is, given the levels of dysregulation and depression with BPD, why is there so little benefit from medication?
Yeah, I think some of that evidence talks about treating the core symptoms of borderline personality disorder. So a medication does not treat, feelings of emptiness or fear of abandonment or, low self-esteem per se. And medications can help with, general mood symptoms, help people be more activated, help people be somewhat less anxious. I think it can help with that. And I actually do see kids, get better with medications. Often they come in on a whole quote cocktail, if you will. And we, it almost always contains an atypical antipsychotic, usually something like Lamictal, maybe Buspar, a serotonin reuptake inhibitor. And by the time they leave, we try to pare some of those back. We really aim for the ones that have the most side effects and see if we can get away with, pulling those back some, almost always Abilify. Usually we don't see a recurrence of symptoms, and the most common response that we get is it didn't really make a difference one way or another. I generally tend to keep and optimize the antidepressant on board, usually an SSRI. And, we also do use stimulants with some regularity with kids on our unit for a few reasons. One is, there's often coexisting ADHD with these kids, and impulsivity can be a real hallmark of their symptoms. And so if we treat the impulsivity with a stimulant and it helps, and they're more able to, be productive in their schoolwork and feel good about that, and, treat that ADHD, they feel so much better, particularly in the era of COVID when, online learning and people weren't kind of having much structure to the day. And we have lots and lots of kids who haven't set foot in a school for 1 or 2 years by now. And so just really, treating some of that ADHD and impulsivity with the stimulant is often quite effective. We see it.
Thank you. For our next question, what is the typical family and patient reactions upon receiving a BPD diagnosis?
Should we both do this one?
Sure.
Yeah.
Do you want to start?
Oh, sure. I would just say, they feel very validated. Families feel like, oh, you understand my child. Oh my gosh, that's what we've been living with. We assign certain readings. At the end of our talk here, there are some websites that we recommend to families, Child Mind, NEA. There are many resources on there. I'd really encourage you to take a look at those links, everything from book recommendations to podcasts, to readings, to videos. There's tons of good stuff. And, when we recommend those to families, they say, oh, my child, and this is so helpful. And then we talk about the hopefulness of the prognosis, and there's language around it, and there's community around it, and there's some ability to communicate more effectively and use skills rather than like, oh, these meds aren't working and we've tried, 12 of them and they start to feel pretty hopeless. So I see that as instilling hope. Usually the parents are pretty open to it. Kids, like I said, sometimes they're pretty open to it too, but maybe they just hold on to some of the more, kind of social media driven things just a little bit longer. For example, the alters or the, I have bipolar disorder. They'll say I have OCD when really it's, more just kind of ruminating about, difficulties or just kind of going over things, but really not OCD as it should be defined and diagnosed. So go ahead.
Yeah, I think one thing that I would say is most notable about this is that I think clinician expectation and fear about how people are going to respond is much more like expecting the worst, expecting people to, yell at them or reject it, or it's going to ruin our therapeutic relationship. And I don't know that we've seen that, certainly not anything different than other diagnoses that we may give on the unit. So I really do think that it does tend to be received well, in the sense that, like, oh, well, this kind of makes sense. And, oh, well, that makes actually more sense than these other things that I've been told. And then people do kind of get more aligned towards moving towards really looking into like an adherent DBT program or similar kind of resources. I do think stigma plays a role, where it is really more clinicians' own kind of emotional concerns that make them avoid giving that diagnosis sometimes. And there is some data on this too that leads to people to be more afraid of giving the diagnosis than really is justified. Yeah.
Thank you. Thank you so much. That's all the time we do have today for questions. And if we didn't get to your question, please feel free to send an email to webinars@rogersbh.org. Many thanks to each of our presenters for taking the time from your clinical practice to share your valuable insights with us. Helping a patient on the road to recovery means collaboration among everyone involved in their treatment. With locations across the country, our treatment teams are ready to partner with you. Rogers Outreach representatives are happy to answer questions regarding our treatment services, as well as to learn more about your practice. Before we conclude, I've asked our presenters to share a few recommended resources on this topic with our participants.
Yeah.
Okay.
Thank you to everybody that joined us today. We were so excited to be able to talk about this topic, and we really appreciate it.
Yeah, thank you very much. And sorry about the technical issues. It appears, of course, now my computer's fixed. These are some good resources that I would recommend checking out. And also the NEABPD also has a number of other talks available that they've recorded and made freely available to both clinicians and patients and families. So that's one thing I would direct people to if they have more interest in this topic.
Thank you. Thank you so much. And that about wraps it up, everyone. I want to remind our participants that those of you who met the required time commitment will be eligible for CE credits. About 30 minutes after the webinar ends, you will receive an email with a link to your personal dashboard on ce-go.com, where you will be able to access PDFs of the PowerPoint slides, as well as a handout and a complete list of resources. Those of you who have met the time requirement to qualify for CE credits will need to complete the evaluation to download your CE certificate for the event. If you have any questions about this follow-up email, please contact support@ce-go.com. On behalf of everyone at Rogers, we look forward to partnering with you to help support your patients. Thank you.
Thanks.